to introduce Max Stahl, who is today's speaker. Max went to medical school in Germany and then was a resident and chief resident here, and then a fellow at Sloan Kettering and Rockefeller, and then faculty at Dana-Farber, and now everybody's caught up. And and we were very lucky to recruit Max here as an assistant professor in April 2025. His positions at Yale included serving as director of the myeloid malignancy and acute leukemia research program. He is the firm chief of the Duffy firm, where he and I communicate quite often. He has done magnificent work ramping up the teaching curriculum on the Duffy firm, for which we are quite grateful. And he also serves as a core faculty member for the internal medicine residency. Max is a widely sought after speaker. He has an amazing publication record for somebody so early in his career, with 63 peer-reviewed original research publications and 58 review articles, guidelines, and consensus statements, as well as numerous chapters to his credit. I want to say just a couple of quick anecdotes. So when Max was the chief resident, we had the pleasure of serving together on the old Fitkin firm. And on our services, one of the big parts of the day is when the attendings get to teach the house staff. And I still to this day remember you're explaining inflammation and cancer to our team. And I think I finally understood what PD-1 inhibitors were all about. And then now, just as I said, what a pleasure it is to have you back here as a partner teaching our residents. So Max's talk today is acute leukemia, what PCCM physicians need to know. I want to take credit for this title because this is exactly what we were hoping you would speak about today, because we get to take care of a lot of patients together. So Max, welcome, and welcome to the podium.
All right. Thank you very much. Thanks for the kind words, Mark. Thanks for the introduction. I was saying to Mark that last time I stood here was actually the chief resident about 7 to 8 years ago. Mark introduced me at that time as well. And the topic was pretty much exactly the same. So I haven't really moved on from AML, although it was not focused on pulmonary critical care physicians. But the title is What Pulmonary Critical Care Physicians Need to Know, and I put need in quotations marks, so we're always available to help and partner with you guys, but I thought it might be good to talk a little bit about things that maybe you could know or that you want to know is probably maybe the better title for this. So here's CME. I'll just keep that on for a second so people can get the code. And those are my COIs. They're also displayed, I think, on that section. I don't think anything is relevant necessarily for this talk here today. So if I learned one thing from Mark as my program director is to keep things interactive, start with a case. So we'll start with a case. It's a 50-year-old man. He's admitted to the ICU with a white blood cell count of 120,000. There's 60% blast detected in the peripheral blood. There's flow cytometry that says something like that: CD34 positive, HLA-DR positive, CD33 positive, 64 positive. It's a normal karyotype, and the genetic panel comes back for an NPM1 mutation. It's negative for a FLT3 ITD or TKD mutation, an IDH1 or 2 mutation, and a TP53 mutation. So when you see this patient in the ICU as a pulmonary critical care doctor, you might ask yourself a couple questions. What disease does this patient have? How do I figure this out? What's the stage of disease? What is the long-term prognosis of such a patient? How will the hematologist treat this patient likely? And what to think about with the treatment that they might want to give? And what complications do I need to be worried about in this situation right now, but also once treatment is actually started? So that's what I will give my talk around today. So I'll talk a little bit about what is AML. How do we diagnose it? What goes into diagnostic things? So when you look in EPIC under the result tab, what do those results mean? And what do hematologists do with those results? How to prognosticate or stage AML? I think this is really important, not only for the oncologist. I think it's also important to frame the discussions with families for critical care doctors, because it's a major difference whether this is a curable patient or whether this is a patient who has an incurable type of AML. And we'll go a little bit about how we decide about that, or what information we use for that. Then I'll talk a little bit how we treat AML, really broad strokes. I show you two major types of treatment that you will see in the ICU again and again. I will talk a little bit about how the field has changed a lot and will change even more so in the next 5 years. And then I'll talk about two complications in AML, particularly pertinent to this patient, apart from neutropenic fever or tumor lysis. So I know you know neutropenic fever very well. I know you know tumor lysis very well. But I'll talk a little bit about hyperleukocytosis and leukostasis, and then differentiation syndrome, which I think is very relevant, particularly with novel therapies nowadays. Okay, so what is AML? So leukemia has always been kind of at the forefront of cancer medicine, I would say. A lot of different types of therapies have first been tried in leukemia, and so also the first use of chemotherapy in cancer patients. This is Sidney Farber, the founder of Dana-Farber Cancer Institute, with one of his patients who he injected with aminopterin, which is an antifolate and really a precursor of methotrexate, which we use today still a lot. And you can see here on the right side a blood smear of a patient before and after. You see those very immature blast cells. And then on the right side here, from the New England Journal article 1948, you see nice neutrophils, showing at least a temporary remission at that time. But what is leukemia at its core? And this is how I explain it to patients. If you think about the bone marrow, even the bone marrow of normal people have blasts, but not too much. And if you think about blasts, they're kind of like cute to look at. So here on the left side, hematologists really like to look at blasts. But they're stuck in their differentiation pathway. And it's almost like if you're stuck in kindergarten forever and you never make it to fellowship or post-fellowship. And there are many steps in between, right? There's elementary school, middle school, high school, graduate school, medical school, and then finally fellowship. And you really need to be subspecialized, right? To be a neutrophil that works well and fights infections, you need to have undergone all those different stages. And a blast is basically when there's a block in differentiation and you cannot differentiate into your normal function. So that's what we see with AML. With APL, or I'll show you this in a second. This is just like what blasts look like. This is what hematologists look like. And when you see their reports, I just want to give you a couple of buzzwords that leukemia doctors will often use when they do a descriptive formulation of what a blast looks like. So if you look at the cell, typically the nucleus is really big and the cytoplasm is really small. That's what we call the nuclear to cytoplasmic ratio is increased. Often what you see is that we talk about something called fine chromatin. That means when you look under the light microscope, you can see the difference here between a lymphocyte and a blast cell. It looks much brighter and this looks much darker. That means the chromatin is open and it's open for gene transcription, which is needed to make more cancer cells. And then usually we see those little nucleoli, little inclusions here. And this is what blasts look like. If they're more than 20% blasts, we call this AML. If you're stuck one stage down, so you made it from kindergarten to elementary school, but you never progressed, that's what we call APL, acute promyelocytic leukemia. So they're a little bit more differentiated. The cells is generally bigger, but they don't progress further that. And APL, I know this is pretty much any question in any medical board forever about leukemia is about APL. So if you know that, you will always answer every leukemia question correct. This is a feared type of AML, of course, because it's associated with coagulopathy. So what does APL look like? If you look under the microscope, this is how it typically looks like. And this is the typical presentation. Most importantly, low white blood cell count is typical for this. So generally, leukemia doctors are less worried about a high white blood cell count. They're much more worried about a low white blood cell count because they're worried that it could be APL. Typically, you see the round nucleus, and you see those hour rods that our fellows always look at night to see, Could this be a case of APL? Do we need to give this patient ATRA? Importantly, there is a different variant that is also APL. And this is often easily missed because this variant, called the hypogranular variant, doesn't have the typical granules here, the hour rods that you see under the microscope. If you look under the electron microscope, you can actually see those. But of course, you don't have an electron microscope in the middle of the night. And those patients present with high white blood cell count. Typically, we say they have butterfly nuclei. So that helps us to think a little bit about it. And then most importantly, they have coagulopathy. So in any patient who has coagulopathy and immature cells, we always think APL, and we always treat accordingly. We give those patients ATRA, vitamin A, even before we can confirm such a diagnosis. Okay, so talking about diagnosis, how do we diagnose AML? So this patient, 60% blasts, going back to this patient, the peripheral blood, and then he has this flow cytometry profile. What does that mean? How do you make sense of that? So this is what goes into a bone marrow biopsy. And you sometimes see us coming down to the ICU when patients are a little bit more stable and even do bone marrow biopsy there. It has two aspects. There's a core biopsy that looks at histology, and often we do immunohistochemistry from that. And then it has an aspirate. And when we do an aspirate, we send many, many different tubes. Okay, so you would see us drawing back a lot of different blood, and I show you some components. What we do is something called an aspirate smear. We do a flow cytometry, we look for mutations, we look at the chromosomes, and all of those have meanings in terms of the staging of the disease. Okay, so this is what a bone marrow looks like, normal and AML. In a normal bone marrow, you usually see these white things here. This is fat, and then you see cells around it. And you want to see this in a particular ratio. What we usually say, the cells should be 100 minus the age. So if you're 80 years old, you should have 20% cells and 80% fat. If you're 20 years old, you should have 80% cells, 20% fat. And if it's either too much or too little, in AML, it would be too much. It looks like this, right? You don't see much fat here. It's all homogeneous spread of leukemia cells. Okay, now flow cytometry. So I'll go a little bit of what flow cytometry is, and I tell you a secret of how to read a flow cytometry report and impress all the leukemia attendings. And it's really not that hard. This is what it is. So we use the cells, we put them in a single cell suspension, and we label the cells with fluorescent tagged antibodies, and then we know which surface markers are expressed on the cells. So here's a flow cytometry report from, let's say, this patient, and you see it's positive for a bunch of numbers, negative for a bunch of numbers. How do we make sense of that report? So here's a simple way of looking at that. They're so-called blast markers. If they're positive, you know it's a blast. You don't know what type of leukemia it is, but you know it's a blast cell that doesn't belong there. And the two markers that are important is CD34 and HLA-DR. If those are positive, we're worried about blasts. That doesn't tell us yet what type of blast it is, but we can do that very simply by knowing what a myeloid cell expresses versus a T and a B cell. Myeloid cells, typical CD33, CD13, T cells, CD3, B cells, CD19, and you know that from CAR T cells because we target CD19. And then monocytes, which I'll get to in a little bit later, express CD11, CD14, CD64. So in practice, it looks like this. If you see CD34 and CD33, it means it's a blast and it's a myeloblast, so it's AML. If it's CD34 positive, CD19 positive, it's a blast and it's a B lymphoblast, so B-ALL. If it's CD34 positive, CD3 positive, it's a blast and a T lymphoblast. And lastly, if you're CD34 positive, CD64 positive, you have monocytic AML. So just looking at that report, what you look for first is CD34. So it's positive for CD34. This is the blast. CD33, it's a myeloblast. It's negative for CD3 and CD19, so it's not a B or a T lymphoblast. And lastly, it's also positive for CD64. So that would be a monocytic AML, right? It's a blast, CD34 positive, CD33 says it's myeloid, CD64, it has a monocytic differentiation. Luckily, the pathologist will often give you the interpretation, but it can be a little bit delayed, and anyway, I feel it's nice to know what you're looking at, and it might help, conversations just a little bit. And it's certainly very impressive for hematologists if you say, I looked at the flow and, this looks like what the patient seems to have. There's one caveat though. If you look at blasts, and we always teach this to our fellows overnight, flow is not good for APL, okay? Because when you're APL, remember I talked about it's the earliest stages, kindergarten, and APL cells already progress to elementary school, they lose CD34 and HLA-DR. So they're CD34, HLA-DR negative. They're very CD33 positive though. So when we see an immunophenotype like that, you would sometimes see in our consultation notes, even before we know whether they have a 15-17 translocation, this is worrisome for APL because they're our rods and they have an APL immunophenotype. This is what an APL immunophenotype is. It's CD34 negative, HLA-DR negative, CD33 very strongly positive. So when we see that, then we always want to start ATRA right away and monitor coagulation very closely. Okay, then we send lots of different mutations. And usually when we do our consultation notes, we say exactly what to send, but they're different panels, single gene panels, comprehensive panels. They all come in at different times, and that's why we send a lot of those, because single gene panels such as FLT3 and NPM1 come back within 2 to 3 days, so they help us screen for the right trials, while other panels are much more comprehensive. One question that I think always comes up from when we consult on those patients is when to get a bone marrow biopsy, right? What do you do? Do you really need a bone marrow biopsy if you have, like this patient, 60% circulating blast cells? The short answer is you don't need a bone marrow biopsy, okay? At least not to make the diagnosis. Often we will do some genetic testing first, and if we screen them for trials, we will need a bone marrow biopsy because the trials mandate a bone marrow biopsy. But we want to wait for the patient to not have a patient undergo twice a bone marrow biopsy, when really one time it's enough. There's some things that we can't tell from the blood, such as how scarred the bone marrow is. So when we look for fibrosis in the bone marrow, we usually want a bone marrow biopsy. But for the purpose of diagnosing the leukemia and characterizing it closely, if we have circulating blasts, even a little bit of circulating blasts, even if it's only 2 or 3% blasts, we usually can do a lot of diagnostics from the blood. Particularly the genetic diagnostics are very simply to do from the blood. Okay, so how to prognosticate stage AML? I think this comes up a lot when we talk with ICU and critical care doctors, because I think it really matters, right? Is this a patient who has a very curable disease and is temporarily extremely sick? And can we get this patient through this episode of sickness? Or is this a patient who has a very poor long-term prognosis anyway from the leukemia? I think this often informs goals of care discussions with patients. And I show you a little bit how we stage AML. And patients always ask for this: what stage is my leukemia, right? And the simple answer is there's no stage in leukemia, because staging is based on how far spread a cancer is, right? So a stage 1 breast cancer is limited to the breast. A stage 4 breast cancer has spread to the liver or to the bones. Leukemia has always spread because it's in the blood, right? And blood is everywhere. So I think it's important to mention that we can't stage AML, but we have very sophisticated prognostication methods that are equivalent to staging. And I will show you how that works here in a second. So this is where it gets a little bit complicated, but don't worry, we won't spend that much time on this. There are probably 16 to 22 different subtypes of AML if you want to count them, and they're all based on different genetics. However, you can bring them in different groups, and the different groups are here. And this is probably the one paper, and I have this at the end of my presentation, some helpful papers for leukemia. That's the one paper you need to know for leukemia if you want to understand AML more. I don't think you need much more than this one paper. And table 6 in this paper groups patients by their genetic characteristics into either favorable, intermediate, or adverse risk. And I won't talk about all those genetic findings, but there are a couple things, just to mention. There's so-called core binding factor leukemias, which have translocations in certain chromosomes, which are very favorable. Mutations in CBP alpha are usually very favorable. And on the other hand, there are things like TP53 complex karyotype, when you have a lot of different changes in the cytogenetics, those are very poor prognostic markers. And this is generally, you know, how it looks like for long-term survival. So when you think about the favorable risk patients, they have a survival of 60 to 70% long-term survival cure rate at 5 years and longer. Intermediate patients have around 30 to 40%, adverse risk about 10 to 20%. And this includes transplant. So it's a big difference, right? Whether you talk about a patient in this survival curve or whether you talk a patient in this survival curve. It makes a huge difference when you try to approach families about, you know, what is my long-term outcome? If I get through this ICU admission, will I likely be cured of this disease or not, right? And this is, I think, sometimes when it's helpful when, you know, when we are part of goals of care discussions, which I know you are always so nice to involve us, but it also helps you guys to understand what are the oncologists talking about when they talk about favorable risk disease versus adverse risk disease, right? There's, of course, no favorable AML, right? I don't want to say this is a favorable thing to have. It's always bad to have AML, but even within it, there are gradations. And, you know, sometimes we use a traffic light principle of green, yellow, red. Okay. So just doing practice for this type of patient, right? The first thing was there was a normal karyotype. Normal is always good, okay? At least not adverse. And then the patient was positive for NPM1, negative for those other mutations. So just going back to this table, you would find this patient right here, right? Mutated NPM1, no FLT3 mutation, normal karyotype. This would be a favorable risk patient. And when we look at the survival curve, this patient would be on this upper curve, right? So a pretty good chance of achieving long-term remission and cure with chemotherapy. And this is actually chemotherapy alone. This would not even include transplant, right? So those are the patients where we really try to push through even when they're sick because they have a pretty good outcome. And sometimes for patients, it helps to put this in frame with other kind of stage 4 cancers, right? You know, if we would have a 60, 70% cure rate in pancreatic cancer or, you know, metastatic renal cell cancer, we would be, you know, happy about that. But we want to push this curve, of course, higher because there's still patients who die of this disease, even when they have favorable risk disease. Okay, how to treat AML? You know, what are the big strokes of therapy in AML? So this is kind of a simplified algorithm of how to treat it. You know, there's newly diagnosed AML and there's relapsed refractory AML. I think this is where the big roads divide. Is this a patient who comes in new to the ICU, didn't have AML before, didn't have any treatment, or is this a patient who had prior lines of treatment already? For newly diagnosed AML, we think this is how we currently think about it, not how we think about it maybe in 5 years, but currently we think about it if you're younger, and younger means for us less than 75, and you're fit to get chemotherapy, so you don't have, you know, cardiac or liver or pulmonary abnormalities that would preclude that, versus you're older and unfit. If you're younger, you get what we call intensive chemotherapy, and this is a classic 7+3 chemotherapy, which I'll talk just a little bit about. And often we add targeted therapy to it if they have a target. If they're older than 75, they get something called HMA or azacitidine plus venetoclax. And just in this room, has anybody heard about venetoclax yet? It's like our new, Mark has, of course, Mark is very well read. So it's our new favorite tool. You know, I think if you take care of AML patients, you will hear about venetoclax. And I tell you at this year's big hematology meeting, this entire algorithm is going to change because what we have found is that this less intensive treatment with venetoclax is probably just as good, if not better, than intensive chemotherapy, at least in a subset of patients. And I'll talk about that. But this is a basic regimen we use for newly diagnosed patients. If they have relapsed refractory disease, they usually get venetoclax if they haven't gotten it before. So every AML patient at some point will get venetoclax. It's very hard to not get venetoclax when you have AML. And if you have a targetable mutation, such as a FLT3 or IDH mutation or NPM1 mutation, you get inhibitors for that. And I'll talk a little bit about that because they can lead to a very interesting phenomenon called differentiation syndrome, which they sometimes end up in the ICU for. And then all patients, we consider an allogeneic stem cell transplant, and we consider them for clinical trials. So in our group, we have a lot of clinical trials. And it's not only for relapse refractory patients, so not only patients where no other treatment has worked, we have a lot of upfront clinical trials, which treat patients with add-ons to the standard of care therapy to try to improve their outcomes right from the beginning. Okay, and this is transplant. I know you see a lot of transplant patients, of course, in the ICU who are sick with complications from transplant, but this is how we think about it. This was a table that I just showed you with the favorable, intermediate, and adverse risk patients. If they're adverse risk from genetics, we always transplant them. You know, unless there is a contraindication for transplant, they're too old or have comorbidities, the road always goes towards transplant. So when a leukemia doctor, let's say, sees a TP53 mutation, we can already tell the patient your road will be transplant, right? Because we know we cannot cure this disease without transplant. If it's intermediate, we will strongly consider it, depends on a couple factors. If it's favorable, generally we do not do a transplant. And this is very important for patients because sometimes we can tell them, as long as you respond well, we will not pursue a transplant, at least not in first remission. Okay, so intensive induction chemotherapy, I won't spend that much time on it because I think you guys know this very well. This is called a therapy called 7 and 3, 7 days of cytarabine, 3 days of an anthracycline. We often add other drugs to it depending on the genetic background. There's also another drug called CPX-351, which is a liposomal formulation of this. We use it for specific subtypes of AML. The big risk is deep myelosuppression, high infection risk, high transfusion burden, and early mortality is still probably around 10%. Here at Yale, it's probably less than 10%, but overall in the country, it's 10 to 20%. Prolonged admission, you have low counts for about, 28 days at least. And this is how it's given. It's 7 days of one drug, 3 days of another drug. In the beginning, we do a diagnostic marrow. Usually halfway through, we do a mid-cycle marrow where we look, have they responded? If they have not responded, we give them more chemotherapy. If they have responded, they're done with chemotherapy for this cycle. And then we do a recovery marrow at the end. And when leukemia doctors talk about remission, what does remission mean for leukemia doctors? It means a combination of clearance of the leukemia cells and recovery of blood counts. So it's really both. If you just clear your leukemia cells, you don't recover your blood counts, that's not what we would call a legit remission. A complete remission means less than 5% blasts and your neutrophils are more than 1,000 and your platelets are more than 100. That's what we call a complete remission. Just, one secret, there's nothing complete about a complete remission. Okay, it's a complete misnomer, but that's what it's called. There's always still disease there and we always give more chemotherapy afterwards. Okay, so what is venetoclax? When I tell you now, it's already everywhere. It's a blockbuster drug in AML, I would say, and it's going to be much more out there. I think a lot of chemotherapy in 5 to 10 years, a minority of patients will be treated with chemotherapy. The majority of patients will be treated with this drug. Okay, so what is this drug? And this goes back to apoptosis or programmed cell death, and I'll just explain it here. They're so-called pro-apoptotic factors, such as BAX and BIM, and they go to the outer mitochondrial membranes and they poke little holes in it that releases cytochrome C and tells the cell to die. And every chemotherapy tries to promote apoptosis. It tries to induce so-called pro-apoptotic peptides that induce apoptosis. However, cancer cells have anti-apoptotic proteins, such as BCL2, that can catch BIM and BAX and BIT and binds them, and with that, they're not able to reach the mitochondrial membrane anymore. What venetoclax does, it works somewhat as a decoy protein that blocks that interaction between BIM and BAX and allows them to be freed up and go to the mitochondrial membrane and kill the cell. So when I prepared the slide, I thought of Mark and his favorite team. This is your favorite team, right? Yeah. So, a baseball analogy. This took me actually quite a while because I'm not a baseball fan, but I do understand the game at its very basics. So I'll give you the same explanation using baseball as an example. So if this is I think this is called the pitcher, right? This is the batter and maybe the catcher. So we'll label them. So if the baseball itself is BAX, this is the little protein that you want to shoot into the mitochondrium to poke up a hole and start apoptosis. The catcher is BCL2, right? It tries to neutralize this thing so it doesn't fly into the crowd. And once it's neutralized, it doesn't reach the crowd or the mitochondrial membrane. And this is venetoclax, right? It makes sure that the anti-apoptotic protein, the catcher, does not catch the baseball, okay? It just shoots it out. And if you hit a home run, you hit it right into the crowd in the mitochondrium and you release all the cytochrome C. That's why we love venetoclax, because it will sensitize the cell to apoptosis for whatever else we give, right? If we give chemo, we try to stimulate backs and back. If we give target therapy, we try to stimulate backs and back. So whenever you give venetoclax, it will make any therapy better, right? And that's why you see it now in pretty much every clinical trial. You will see azacitidine plus venetoclax plus target X. And because this is so efficient in triggering apoptosis, it's actually, you need only a very low dose chemotherapy. And this is this hypomethylating agent. It's a treatment that 90-year-olds can get, because you need to induce only a little bit of that because you block all the anti-apoptotic factors, right? And less toxic therapy, this is certainly less toxic. We give it a lot in the clinic as outpatients, does not mean less effective, right? And this is going to be the big plenary session this year at ASH, where they directly compare intensive chemotherapy versus this type of therapy. And this type of therapy was better than intensive chemotherapy, at least for certain subsets of the disease. There's still exceptions. I won't talk about that, but the majority of patients, particularly intermediate and adverse risk patients, will be more and more treated with this type of therapy. And this is the curve initially that got it approved back in 2020, where they randomized patients to azacitidine versus azacitidine plus venetoclax. And those curves look better now because we add different therapies to it. We transplant more and more of those patients. Okay, and those were pretty much, very old patients, unfit patients. Okay, this is how we give it. Azacitidine is given over 7 days, and venetoclax is usually ramped up, because if we give them the full dose, they often undergo apoptosis so rapidly that they're at high risk for tumor lysis. And then we do a diagnostic bone marrow. We do a bone marrow at day 21. And then with cycle 2, we usually cut the venetoclax dose down further. But this is an ongoing treatment. Patients usually don't go off this treatment unless they go to transplant. Okay, then we have targeted therapies, and you sometimes see this with patients who have IDH1 and 2 mutations. Those are mutations that are in the Krebs cycle, and you can inhibit those mutations. And this therapy can be added onto azacitidine as well, leads to long-term survivals. There are drugs called ivosidenib for IDH1 mutation. Olutasidenib is also for IDH1. And then there is enasidenib with an IDH2 inhibitor. And those drugs are particularly important when we talk about differentiation syndrome, which I'll talk about, a typical complication of this treatment that would bring patients to the ICU. The latest treatment is menin inhibitors. You will see a lot of menin inhibitors in your ICU. We have a lot of different trials testing menin inhibitors in the upfront setting. So a lot of patients will be started on chemotherapy or azacitidine, venetoclax plus menin inhibitors. And menin inhibitors promote differentiation of leukemia cells. So they interact with a protein called KMT2A, which is very important for repression of differentiation. And if you block that, you allow the cell to differentiate again, right? So think about the analogy of patients who, or cancer cells stuck in kindergarten, right? You allow them to grow up and do their function. And there are 4 different ones, and there are going to be many more. It's a very hot area of investigation. And we treat a lot of patients who have those 2 abnormalities, NPM1 and KMT2A rearrangements, with this drug, because in those subsets it works. Okay, so going back to the case, so we already determined he has AML based on the flow. We have determined he has favorable risk disease. Now he's being considered for treatment with 7 and 3 plus a menin inhibitor, ziftomenib, and this is because the patient has an NPM1 mutation. Okay, but before we go to the treatment, let's talk about the elephant in the room. The patient had a white blood cell count of 120,000, right? So what to do with that? That usually gets people's attention. And that gets me to the topic, how to manage hyperleukocytosis and leukostasis. So a couple things about hyperleukocytosis, a couple of pearls maybe that might be interesting to remember. is hyperleukocytosis is typically defined as 100,000 white cells, but some other literature defines it as 50,000 white cells. Anything above 50, I would consider hyperleukocytosis. The important thing, high white blood cell does not mean leukostasis. Leukostasis is when you develop clogging of the blood vessels, right? And typically it's brain and lung and heart, and you get end organ damage because of that. But a high white blood cell does not necessarily mean you get leukostasis. Leukostasis is really the cell count and the interaction with the endothelium. And that's why I put this picture up here. Cancer cells can secrete factors like TNF alpha, interleukin 1 beta, which usually upregulates E-selectin and ICAM on endothelium, which then makes the leukemia blasts clog to the endothelium and stick together, and also invade the endothelium and lead to fluid spacing in the endothelium. And that is important, that this part here, the interaction with the endothelium, differs between the different types of leukemia. The other thing that's very important is how deformable a cell is. And so what you see is that leukostasis is infrequently seen with CML, ALL, and CLL. So if you see a patient, with a super high white blood cell count, they have no symptoms, you can sometimes think they probably are ALL or CLL because those cells are much smaller. The lymphoblasts are smaller than the myeloblasts. Or they have CML because most of the CML cells are still mature cells, at least when they're in chronic phase CML. So they can deform, they can go through a vasculature, which myeloblasts cannot. And then typical characteristics of hyperleukocytosis in AML is if they have a FLT3 mutation or an NPM1 mutation. Usually those are mutations that really rake up the white blood cell count. If they have KMT2A rearrangement, and if they're monocytic. And monocytic is very important because monocytic markers express CD11C, and that makes them go to the endothelium. And that makes sense because monocytes already have that as normal function, right? They can leave the endothelium and go into tissues. And malignant monocytes do that as well. The pathology is very clear. The clinical diagnosis of leukostasis is difficult. Okay, there's no gold standard test where you can say this patient has leukostasis, but concerning symptoms are pulmonary symptoms, chest pain, neurological symptoms. So think lung, brain, kidney function as well. But the differential diagnosis is pretty broad too. So you could get similar findings on lung imaging from microhemorrhages, infection, cytarabine, pulmonary damage can give you that once you start treatment, and leukemic pneumopathy itself as well. This is actually data from our cancer center where we looked at does the survival differ for patients less than 100 and more than 100,000? So is hyperleukocytosis itself an adverse risk factor? It is not. So you see here, patients live the same, but the major difference was whether they had clinical symptoms of leukostasis. If you have leukostasis, you do live shorter than if you don't have leukostasis. And the question always comes up, what do you do with those patients? Do you just give them chemotherapy as quickly as possible, or do you do leukapheresis? So do you do a leukapheresis catheter, and do you pherese it out? I'll show you a little bit of data first, and then I show you kind of a practical algorithm that we use in order to decide on whether we do leukapheresis or not. So this is, again, data from our center where we looked at predictors of 30-day mortality and predictors of overall survival. And we looked at patients who had leukapheresis or did not have leukapheresis for hyperleukocytosis. And what you can see here, you don't have a difference in 30-day mortality, and you don't have a difference in overall survival, whether you get leukapheresis or not. Of course, there's no randomized trial, right? It's very hard to randomize patients to you don't get leukapheresis, you do get leukapheresis. But you certainly don't have a long-term benefit, and short-term benefit is also arguable compared to just giving chemotherapy. And this was a meta-analysis we did from all different people who looked at leukapheresis. And again, what you see here is for the early death rate, no difference whether you got leukapheresis or not. And really, when we looked at who got leukapheresis, it was all patients with mainly leukostasis, right? And this has informed our practice. Generally, when we don't have leukostasis, and I go to this algorithm here, if you have a white cell count more than 100,000, you don't have leukostasis, we generally do not do leukapheresis. We just give them chemotherapy or we give them hydroxyurea. It's usually effective in reducing the white blood cell count. If they do have leukostasis, then we consider leukapheresis. There are certain contraindications to leukapheresis. So for example, patients who have coagulopathy, we do not do leukapheresis. So APL patients, even if they have a high white blood cell count, if you do leukapheresis on them, usually the catheter just clogs very quickly. So it's in those patients, we don't do it. In other patients, we consider it. I wouldn't say it's an absolute yes. If we can start chemotherapy quickly, sometimes we do it concurrently. The problem with leukapheresis is, apart from that you need a big catheter, it's also you do a leukapheresis session, and then a couple hours later, the white blood cell count is very high as well, right? It doesn't get rid of the issue in the bone marrow. So often chemotherapy, prompt initiation of chemotherapy is the way to go. So in a patient like this, in this case example, if the patient didn't have leukapheresis, we want to start the patient on chemotherapy as quickly as possible, but we wouldn't do leukapheresis. Okay, so this patient does not have any signs and symptoms of leukostasis, is cytoreduced with hydroxyurea, then started on 7+3 plus menin inhibitor ziftomenib. 10 days into treatment, the patient develops high fever, shortness of breath, is found to have 8 pounds of weight gain since treatment start. And this is what the X-ray and CT scan looks like. So kind of bilateral infiltrates in the lung. And of course, this is pretty broad diagnosis, could be many different things. But the one thing to think about if you got a menin inhibitor or any of the novel target therapies is something called differentiation syndrome. So what is differentiation syndrome? It's when we differentiate a leukemia cell, when we release a block of differentiation and let them differentiate into normal cells. That is, of course, the ideal treatment we want to have for leukemia, right? So not just killing the cancer cells, but letting them differentiate into normal cells. So it's actually a good thing to have that. But you can imagine if you go to kindergarten and within a single day, you're expected to perform the task of a pulmonary critical care fellow, that would induce a lot of stress, right? And similar, that induces a lot of stress in those white blood cells. And they get really stressed out. They release a lot of different cytokines while they do that. Proteases, they increase the expression of integrins, adhesion molecules. So you get a lot of inflammation, microinflammation, and that can lead to a SIRS-like picture with capillary leak syndrome, organ infiltration by maturing cells, including monocytes, endothelial damage, coagulopathy, and it can look exactly like ARDS, basically. Okay, so a couple things about differentiation syndrome. They can be seen by atra-arsenic. That's a typical differentiation syndrome that has been described for many, many years for the typical treatment for APL treatment. And because differentiation is so effective in APL, that's why we cure 95% of APL, right? So if we would have differentiation with other agents to the extent that atra and arsenic does, we would be done with AML, right? So differentiation is a good thing, but the complication of it needs to be managed. So you see atra-arsenic, but it can also happen with IDH inhibitors, can happen with FLT3 inhibitors, and it can happen with menin inhibitors. And I put a little bit here the rate of those in there. So for FLT3 inhibitors, for example, it's generally rare to have that. It's quite common with atra-arsenic, and it is quite common with those menin inhibitors. So I think that's something to be aware of, particularly now that we're doing a lot of trials with menin inhibitors, that you will see some patients with differentiation syndrome. I also put slight differences on the median time to onset. So that differs a little bit with atra-arsenic. Usually in the second week, you get it. With IDH and menin inhibitors, it can be delayed even later in the cycle. And some patients have severe differentiation syndrome, which is a minority of patients, but those cases can be very severe. A couple things here about it, that the frequency and severity of differentiation syndrome depends on all those different factors. So disease burden matters. If you have more blasts to differentiate, you have a big volume of white blood cells that can release cytokines. So blast percentage, white blood cell count matters. The drug itself matters. So atra-arsenic, higher differentiation syndrome than menin inhibitors, more than IDH and FLT3 inhibitors. So it really matters what type of treatment you gave the patient. It matters what type of disease you have. So APL is the classic factor of differentiation syndrome, as I mentioned. But even within menin inhibitors, it matters whether you have an NPM1 mutation or a KMT2A rearrangement, because they're differently sensitive to to differentiation therapy. So typically KMT2A rearranged leukemia patients have a higher risk for differentiation syndrome. And what probably matters the most is what they get with that agent. So if they have a lot of white blood cells and they only get a targeted therapy, that depends entirely on differentiation, and they don't get chemotherapy with it, then they're at high risk for differentiation syndrome. So patients who get chemotherapy, like this patient, chemotherapy plus a menin inhibitor, the differentiation syndrome rates have been much, much higher than when those agents have been given as single agents. Important is also whether steroid prophylaxis is used or not. In APL patients who have so-called higher risk APL, so a white cell count more than 10,000, we usually give steroid prophylaxis before we start it. For those newer agents, steroid prophylaxis is in fact not standard of care. So a lot of those patients will not be on steroid prophylaxis, although the field is thinking about for menin inhibitors, whether we should give those patients steroid prophylaxis similar to adagrasib. And then the clonal architecture also matters. What type of clones they have, how many patients have the mutation that is sensitive to differentiation therapy. Okay, so a couple of things about differentiation syndrome. This is adapted from APL, but it's true for the other agents as well. Usually we look at features of differentiation syndrome, so fever, weight gain, hypotension, shortness of breath, radiographic opacities, pleuropericardial infusion, acute renal failure. If any of those present, you should at least think about differentiation syndrome. Of course, that doesn't help that much because in the ICU, a lot of those things are present in most of your patients. But if you have a targeted agent that can cause that, that should certainly be on the differential. And then we grade differentiation syndrome depending on what the features are, how many features are present. If more than 4 features are present, that's what we would call severe differentiation syndrome. A couple of things about empiric treatment. The empiric treatment is dexamethasone 10 milligrams every 12 hours. We can increase that frequency if needed. Generally, we try this because there's no gold standard test for differentiation syndrome. And if they get better, then we think it was probably that. What to do with the drug itself? So generally, if it's severe differentiation syndrome, we hold the drug, but be mindful that a lot of the target therapies have really long half-lives. So IDH inhibitors half-life is 4 days. So until that drug is out of the system, the patient is either better or in real big trouble, right? So often holding the drug doesn't do that much. Steroids probably help a lot more. And then you do aggressive supportive measures, as I know you're doing in the ICU, and you're trying to rule out all the mimickers such as sepsis, pulmonary embolus, diffuse alveolar hemorrhage, congestive heart failure, et cetera, et cetera, et cetera. The list is definitely long here. And then I talked a little bit about prophylaxis of differentiation syndrome. So if we have an APL patient with more than 10,000, we think of this patient very high risk for differentiation syndrome. We usually give them 0.5 milligram per kilogram of prednisone for at least the first 2 weeks. And we're rethinking whether we should do this for our menin inhibitor patients as well, at least those patients who are treated with single agent menin inhibitor. If it's combined with chemotherapy, it's usually a rarer circumstance that they get differentiation syndrome. Okay, so this is what we talked about today, and I will just want to leave a little bit of time for questions. I talked a little about what is AML, how do we diagnose it, how do we stage or prognosticate, what are the treatments. I talked particularly about venetoclax because I think you will see this treatment in pretty much any AML patient very soon. How to manage complications in AML that is not neutropenic femur tumor lysis, mainly hyperleukocytosis and leukostasis, the role of leukapheresis, and differentiation syndrome, which is well known with APL, but is also present with a lot of our targeted agents that have been developed over the last couple of years. And here is kind of the top 4 papers that I would recommend. This is the paper that I mentioned that basically summarizes all of AML for you. It comes out every couple of years by the European Leukemia Network. It has that table 6 that I mentioned, which is really helpful figuring out, is my patient in a favorable versus intermediate versus adverse risk category? And then Blood has very nice articles of how I treat patients. So there's one article, how I treat patients with azacitidine plus venetoclax. That might be useful thinking of how common this treatment will be, how I treat hyperleukocytosis and acute myeloid leukemia, and how I treat acute myeloid leukemia with differentiation therapy. I think those are all relevant to this talk. And this is our team, all the attendings and APPs that you see. I would say we're always available for you. If you need us, just call us. Here's my cell phone number. if you want to, take it down. We're always very reachable, and we want to help with our patients. We realize they're very sick and they're on complicated regimens, and sometimes we are in a great time pressure getting them on trials, particularly now with frontline trials. Many of our patients are sick and still are going on trial, and I think good communication is always helpful. So we're always happy to chat about any of those patients. And thank you for the invitation. Thank you, Mark, and thank you to all of you.
Thank you for that comprehensive talk, Max. It was exactly what we needed to hear, and I really appreciate it. The floor is open for questions. Maybe I'll start. So one thing I've always been interested in is the kinetic of leukemia. And on the ICU side, what we often see is somebody who is flown in here by y-axis because of a brand new diagnosis, white count rapidly rising. And I'm wondering, how fast do you need to get in there and start treatment? Because inevitably it's 11 at night or 1 in the morning.
Yeah.
So what are your thoughts on that?
Yeah, I think that's a great clinically relevant question. I would say that's a question that we try to teach our fellows as well, because they're sometimes on the first line, need to decide how quickly a patient comes. So a couple characteristics that we care about. The white cell count is definitely one. The more important things that we really worry about is when we hear a high white blood cell count, we ask them, are there any concern for leukostasis, right? So if this is a patient who has already chest pain or shortness of breath or has neurological symptoms, it's an absolute emergency and they should absolutely come, and we should consider leukapheresis and intensive chemotherapy that night, to get the white blood cell count down. If they already don't have leukostasis, I think there is some time, and often we put those patients on hydroxyurea or give them a gram of cytarabine. We're able to get the white blood cell count down and at least stabilize them. The other thing that we always warn about is coagulation tests, okay? And this helps really very much in triaging. So I can't tell you how often I got calls in Boston from centers, in Maine or New Hampshire, local emergency rooms, and they read me the labs, and the lab that is always missing, because it's not part of coagulation tests usually in emergency rooms, is fibrinogen. It's probably one of the absolute most important things in leukemia, because if that is low, we are worried about APL. And APL is an absolute emergency. And a lot of local emergency rooms do not keep ATRA, because they give it so infrequently that it's not worthwhile for them to keep it in their pharmacy. And those patients we actually want to have even helicoptered here, because those patients are at very, very high risk for spontaneous bleeds. And we have had several cases where they arrive and they are getting their head imaged and they already have a subarachnoid hemorrhage. And it's really devastating, particularly for a disease where the cure rate is 95%, right? So I remember just, your comment brought this up. I tell you a simple anecdote. I had a patient at Dana-Farber where I got a phone call. He was a Marine in Charleston, and he couldn't hear. And his drill sergeant yelled at him so long, but he really couldn't hear. So eventually they put him to the infirmary and got abnormal tests, and he had abnormal white blood cell count. He called his grandmother in Boston. She drove there and drove him up, and he had APL, and we knew that because while they were en route from Charleston to Boston in the car, the fish came back, in the emergency room in Charleston, and it showed 1517. So when he came, we did a CT scan immediately, and the guy was like, I'm okay. And he already had a brain bleed, right? However, he did well. He was stabilized in the ICU there. He got ATRA. He's cured now. I saw him 2-3 months ago. He is in gardening business. He didn't go back to the Marines, but it's really that recognition that if we see a low fibrinogen, we get really worried. If we see leukostasis, we get very worried. If it's a high white blood cell count by itself, it doesn't worry us that much. Not that we should ignore it, but it's not something where we would freak out. Yeah. It's a great question. Yeah.
Jeff, just, I love your baseball.
Jeff, just give it.
I think it was really helpful. I do think you might want to rethink being a Mets fan, but I may not be the best fan to be for your drug. But I want to just ask about HLH-MAS. and whether that is something you see in the leukemia patients, because that seems to be a lot of what we get, patients sent to us for in the MICU these days, and what your kind of comments are about that and advice.
Yes, yeah. So HLH, and macrophage activation syndrome, we see it mainly. I think the main patients where we see it is in cellular therapy patients, so that's where I've seen several cases of this, and the problem is it's similar. There's no clear cut diagnostic where you say this is what it is, or it's just a patient who's very ill from sepsis, However, we do get worried if they have, if they're very sick, they're very inflamed, and a lot of the inflammatory markers are incredibly high, and then we try it, and there's no perfect treatment for this either, right? So we have, we can give things like tocilizumab, but we can also give things like anakinra, and often it ends up being, we give patients a kitchen sink, often they get high-dose steroids, and we try to make them better, and some patients just don't get better despite steroids, anakinra, tocilizumab, and there's probably something we're missing about the pathophysiology that just doesn't allow us to target it perfectly. But the cases where I have seen it mainly is after cellular therapy. I have not seen it a lot with like chemotherapy or targeted therapy, but with target therapy, but with cellular therapy can be devastating, and we had a couple of cases where we just could not reverse it, even with, with those medications that I mentioned. There is now some in the cellular therapy world, not that I'm a cellular therapist, but just, some experience with that, is that people more and more think about stopping that inflammation right in the beginning, So initially when CAR T cells were made, right, and done, the last thing you wanted to do is reduce cytokines because you were worried that the T cells couldn't work, and that is definitely, that pendulum is swinging back, So there are people now who give tocilizumab prophylactically, right, to not even get to that fire that then can cause a lot of issues down the line. But I think those are still in trials, For our patients, we typically don't do that yet. But although the transplanters would know, maybe they have already started doing, prophylactic tocilizumab to prevent some of those things. Because when it happens, it can be devastating. Yeah.
You're mentioning the white blood cell count, but also other things that influence having leukostasis. Do you ever worry about that in CLL as well, or because it's lymphocytic, it's not a higher concern? And do you also do leukapheresis in CLL at some cases, or it doesn't really matter?
Yeah, great question.
Thanks.
It's almost impossible to get leukostasis in CLL because the cells are so small and they're nicely decompressible still, And in CLL, it's not even, in ALL, we're sometimes worried that if you get your blasts very high, because those are lymphoblasts, they're still bigger, right? But in CLL, they're actually mature lymphocytes, So they're not even lymphoblasts yet, right? Unless you have Richter's transformation, which is a little bit of a special case. But in general CLL, even if you have a very, very high white blood cell count, you wouldn't get leukostasis with that. You can get many other things like tumor lysis syndrome and other things, but leukostasis is not something we see with CLL, and so we would not do leukapheresis in those patients either. Really the patients where we see it is AML patients. We don't even see it much with ALL. We certainly don't see it with CML, which is another myeloid disease. And CML can sometimes have the most impressive white blood cell counts. There can be people who have 400, 500,000 white blood cells, and they get transported to the ICU and they're totally fine, right? Those are often patients who don't have AML. If you have AML blasts and you have 400,000 white cells, you usually have leukostasis, I would say.
We were able to do leukapheresis here.
Yeah, we're able to do it, although we don't do it very often, because in those patients, we would give them cytarabine. We would give them a gram of cytarabine, and the next day they're like half their white cell count, right? With leukapheresis, by the time you're done leukapheresing a patient with that type of white blood cell count, you check a white blood cell count a couple of hours later, and it's already starting to go up, and it's like, halfway there, right? So it's generally chemotherapy, I think, is a more effective way of lowering it. Sometimes we do both, right? If somebody is has terrible leukostasis, no coagulopathy, we do both. We do leukapheresis and we do chemotherapy. The one thing I want to say about hydroxyurea, because that gets used by us a lot, it takes time. Okay, hydroxyurea is not a drug that kills cancer. It prevents making of cancer, right? So it's a little bit like rasburicase and allopurinol, if you think about it, right? You know, if you already have a uric acid of 16, allopurinol is not gonna fix that. You need rasburicase, right? Similar for like, if you want to really kill cancer, you would need cytarabine. You know, hydroxyurea would take like 2 or 3 days to work. So when we put patients on hydroxyurea and their white cell count is lower the next day, it's not the hydroxyurea. It's the fluids that you gave. You know, it diluted that out basically, right? But still, hydroxyurea is very important because by 2 or 3 days, then the white cell count really goes down nicely. But if you need immediate relief in a patient with leukostasis, it probably makes sense to give true chemotherapy. You know, the problem for us is sometimes, you know, it makes them ineligible for any frontline trial. Most of the frontline trials are written by that you can give hydroxyurea, but not cytarabine. You know, not that that matters. If a patient needs it, right, and they have leukostasis, we would rather do that. But that's why we don't give a lot of cytarabine if we don't need it, because it would usually, it's an eligibility criterion that excludes them from any frontline clinical trial. Unfortunately, shouldn't be that way, but that's how they're written. Yeah.
Well, Max, thank you very much. It's 4 o'clock. Magnificent talk. Thank you for teaching us, and we hope to have you back again.
Thank you very much. Yeah.